Okay, welcome everybody to tonight's event on quality improvement activities for emerging risks. Welcome to those that are attending via webinar. This evening we've got approximately, I think, 30 registered for a webinar, and here in the Geelong office we've got about 22 or so attending. I'd firstly like to just acknowledge the traditional owners of the land, the Wathaurong peoples, and pay my respects to elders both past and present. For those that are on webinar, we have attached the handouts for tonight's event, so the slides with note pages and also the QI activity template. You'll find this under the handout section on the sidebar for the GoToWebinar. Also, if you have any questions, you can type that into the questions box and we will answer those during the night for you. There will be a part of the evening where there is a bit of a break, and also then when we come back to do some of the QI activity work, where you can do that work on your computer by downloading that QI activity template. The people here in Geelong will be working on theirs at their tables, either singly or in groups. So if you do have any questions during that time, just use the question box to ask questions, and Angela, our presenter tonight, will be able to answer those for you. So I'd like to also acknowledge our sponsors for this evening event, and Angela Mason-Lynch, who is with Advance, is presenting this evening. So Angela has extensive experience managing practices of various disciplines and size. As a past state and national AAPM president, fellow life member and certified practice manager. She has experience as a board member and expert committee member for multiple bodies in healthcare. Angela is an accreditation surveyor and a trainer and assessor for UNEP, a registered nurse with postgrad certificate in nursing management, a diploma in practice management, and is a graduate of the Australian Institute of Company Directors, and has a history of commitment to ensuring healthcare is delivered safely with quality outcomes in a financially viable environment that is a desirable place in which to work. So I'd like to welcome Angela here this evening. So she's made her way from Horsham last night to Geelong tonight, coming from Sydney.
So I did enjoy it. I did enjoy that drive across. It was beautiful.
There's that for
Thank you very much. Great. Thanks. So welcome everybody tonight. We're going to talk about quality improvement. What a boring topic. It's actually not boring. I want to talk about it from the perspective of risk. So working with the band, I've only worked with the band for a year. Prior to that, I've been in practice management for 20 years. So I think it's been really interesting making that transition across to an insurer of doctors. My role at a band, what I get to see is some of the phone calls that come from practices that have had complaints against them. They come across my desk if they've got anything to do with a system failure or a personnel failure, within the practice team. It astounds me, some of the things that come across my desk. I sit there and I go, oh my God, how are we in goodness name supposed to prepare our practices for something like this? So I come here tonight with the information of currency, with things that are going on currently out there, and with how you might be able to adopt a quality improvement activity against those things that are going wrong. So I'm going to use a lot of cases as well, a lot of actual cases and actual case studies that we have in a band. I want you to have a look at that. I love this quote. Do the best you can until you know better. Then when you know better, do better. And it really makes sense, but the problem that we have is when do we know that there's something better out there? When do we know that it's time to move on? So I'll give you some tips over the next hour on how you will work out what's going wrong or what you need to be prepared for. We're going to work for about an hour with me talking to you and explaining the QI process. And then after that, we'll have a little break, probably for about 10 minutes, and we'll come back and we'll work on how to actually populate the template in front of you, which is a standardized template. So, pick QI. We know it's there. When did it come into play? August 1. August 1. There's 4 things that we have to do to qualify for PIC QI. We have to be accredited or eligible for accreditation. We need to register for it, which you can do from the 1st of August, and I think you've got until November until you might miss out on money. You have to submit clinical data to your PHN. So what are you using here? Most of you, ChemCat, Cat Plus? Yeah, is anybody using the other one, Polar? No. Oh, or Pen. Okay. Does anybody have any problems with this, with submitting data? The reason I ask is that at Avant, we get a lot of phone calls about this, and for the PHN staff, you'll be interested to know this. So there's obviously a contract that you have to sign with the PHN, and a lot of practice managers are ringing us at Avant and saying, should I be signing this? I'm handing over my data to the PHN. Am I allowed to do that? Am I in breach of the Privacy Act and so on? I can reassure you that you're not. It's de-identified data, so you're quite safe to hand it over, which obviously the PHN have given you that information because none of you are concerned about it by the looks of things. The last thing that we have to do to meet the QI PIP criteria is to perform PDSA quality improvement activities in our practice. That's the one I'm going to talk about tonight. It's so much easier than what we originally thought. So I don't want you to be concerned about it, and by the end of tonight you won't be, I'm sure. QI quality improvement's been around for a while. The 5th edition standards, when did they become mandatory? October last year, yes. We had a year that we could choose, but from October we had to be accredited under the 5th edition. So it was already written into the 5th edition standard. So that's been around for a while anyway. So we're supposed to be doing it. Now your surveyors, if you've been recently accredited or surveyed, they might not have asked too many questions about it because it was fairly new. Let me tell you, they will be now. So they will be wanting to see evidence that you're actually performing these activities and how you're involving the team. The 5th edition is very much about the team and getting the team involved in the whole practice. And that's tough because often we find that our admin team, our receptionists, are really only there to put groceries on the table. You know, their heart may not be in their job, and that makes it really challenging for us as well. I'm going to give you some examples over this next hour of where I've seen a QI activity actually turn that around. So it can give these people a bit of ownership that are working in your team and make them contribute to the practice and feel positive about the practice. So I will share that with you. So QI 1.1 right through talks about what you're doing in your practice, how your team are talking about quality improvement, how you're gathering that data, how you're using them, how you're reporting back to them, and so forth. It talks about patient feedback and you know whether or not you're looking at patient feedback and doing anything with it. And let's face it, some of the patient feedback we get is rubbish, but some of it might be, you know, quite reasonable and quite relevant. So we should be looking at that. And certainly I know that other customers in industry are surveyed about what they want from the business. So we probably should be asking our patients what they want so that we can use that to quality improve. I do have to say though that I think we've got I think we're a bit behind the 8 ball there because I don't think general practice has got a good name. I think we let our customers down sometimes. You know, they have an appointment, they don't get seen at the appointment time, they can't see the doctor they want to see, they don't understand why they can't ring up and just get a script. So we were actually behind the 8 ball a little bit there anyway. So I think it's really important that we do find some way of interviewing them or asking them what they want and working on that as a quality improvement activity. It's all about seeking feedback from the team. Again, these are just your criteria within accreditation. Talks about business risk management as well, which can be part of your QI. It also talks about it in the core. Okay, so let's talk about the types of things that you might quality improve on. So we're very used to thinking about quality improvement from a clinical perspective. You know, our doctors are told that they have to improve HbA1cs, they're told they have to, or they were told they have to do SIPs, service incentive item numbers, you know, for diabetes, asthma, cervical screening. So QI has often been linked to a clinical outcome, but it doesn't have to be. It doesn't have to be. It's about improving your practice. So if improving your practice by having better smoking history is an improvement, that's a great improvement. If you decide to improve your practice by decreasing waiting times, that's an improvement. If you just decide to improve your practice by having happier staff, you know, improving staff morale, that's an improvement. So it doesn't have to be, you know, where the HbA1cs have improved. It might be, has your morale improved? Has sick leave improved? You know, has staff turnover improved in your practice? They might be things that you want to concentrate on as a quality improvement. So it's really very much up to you as to how you want to improve the service that you are providing. And I think what's happened in our industry is our customers, our clients, our patients, their expectation is here. There's no doubt their expectations have increased over the past few years, many years. Our deliverable is even lower because we keep getting, you know, legislative changes given to us. We get different rules and regulations. We get different standards. So our deliverable actually gets harder. And a perfect example is 3 points of identification. You know, we're supposed to have been doing that during the 4th edition standard. So we're supposed to have been doing that for about 8 years now. But it's really hard to do because your staff probably think if I do that, I'm going to breach privacy. And your patients are saying, well, I'm not telling you who I am. You should know who I am. So it's a perfect example of where the deliverable is here. Sorry, the expectation is here. The deliverable is here. So a quality activity can be very much just looking at how we might close this gap. So how might we lower the expectation, and that might be around patient education, or how might we increase our deliverable? So it's about trying to get this balance. And I think sometimes we have to spoon feed our team a little bit about trying to get that a little bit more equal. And sometimes you've got to actually ask those questions to find out what that expectation is. We've already talked about patient feedback, but we also have to ask our front desk people, our front of shop people, what are patients expecting and what can we actually do? Because I can't come out of a doctor's meeting and go to my front desk and say, we've got to start doing this. I've got to ask the receptionist, are we able to start doing this? Because they might say, absolutely not, Ange. The patients are going to complain and I haven't got time. So, or the good old, I don't get paid enough for that. We get that a lot too, right? So we've got to somehow work out how we can get them to buy into this. So when your quality improvement, when you're deciding on an activity, it might be around just structures. So I'm talking there about, you know, just the way things happen in your practice. It might be your systems. You know, your policies and procedures, the way you do things. So is there something you're doing that you might need to change? Do you have to change something because something's changed outside your practice? Okay. What would have changed in all your practices on or before the 1st of July this year? What happened on the 1st of July this year? Shared debt recovery? Yes. What should we have changed in our practice to make sure that we prepared for shared debt recovery? we should have changed how we bill in our practice, because we have to now show Medicare in an audit, if need be. We have to show them that only the practitioner directs item number billings, that the receptionist doesn't do it. And this is a big deal for us, because when you do your resubmits, does the doctor instruct? When you do, when the doctor's busy and runs out of his room and into the treatment room, and they haven't told you at the front desk what to bill this patient, who's deciding what to bill it? Or do they ring up and say, doctor, you haven't told me what to bill, and the doctor says, oh, 23, 36. And they go, right, thanks. Can't do that anymore, guys. I mean, you might have a great relationship with your doctor, but let me tell you that when a doctor is asked to pay, in June, it was one GP was asked to pay $520,000, he or she, or he in this case, is going to do everything he can to share that debt responsibility. So if he can say, oh no, my receptionist billed that, I didn't know that she would have billed that, I reckon it's only a matter of time before that's going to happen, and all of a sudden you're going to be responsible for that debt recovery bill. So this is a legislative, and we'll talk a lot about, you know, the emerging risks and how you identify them, but that's a perfect example of where something happened outside your control that you now need to work out, okay, we need to change our system, which means you need to sit down and nut out how you're going to do this, and you will have to involve your team, because you'll have to know what they can actually do, and you'll have to give them the words to say to a doctor when the doctor says, just bill them a 36. You're going to have to give your team the words to say, I'm sorry, you've got to send me a note. You've got to send me a message. You've got to give me some evidence. So your systems might have to change, and that might be a quality improvement activity. It might be around clinical care. So it might be you're trying to increase chronic disease management item numbers. You know, that might be an item number. Who's looking at the, what is it, the 699? Is anybody using that yet? Starting to? Yeah. Yeah, it's a good idea to have a look at how you might implement that. And just a little bit of a hint, I did hear that it's only going to be around if we use it. It's only, I think it's flagged to be there for 2 years, and then they're going to take it away unless it's being used. So if you think it's going to be beneficial to you, you should probably start talking to your doctors about how you can use it. So involving the team in your quality improvement activities is a huge part of getting it right, so it actually gets achieved, but also giving them an ownership of it. So I'll give you an example. Does anybody know a doctor called Dr. Andrew Knight? I worked with Andrew Knight recently, but back in 2001, and now that's a long time ago. Back in 2001, Andrew Knight he's a GP in the Blue Mountains. He did a PDSA study, a quality improvement activity in a PDS study around wait times. He ended up lecturing about it all over the world. That's how amazing it was. He wrote papers and so on. Basically what happened is he said in 2000, and it was probably about 2000 when he first did it, he said, I'm sick of running late. My wife hates it when I'm late. I hate it when I'm late. My staff hate it when I'm late. My patients hate it when I'm late. All those people are making my life unbearable. Patients are coming in and they're complaining for the first minute of the consultation. Receptionists are taking multiple phone calls asking, how late is he? Patients are bucking the system. You know, they're bringing their kids into a consult because there's no respect for the appointment time. And I'm guilty too. I'm talking about fishing instead of, you know, the problem that they're here for. And my wife, well, I'm not even going to go there. So this is what he said. So he said, right, it's March. By the 1st of September, I am not going to run late anymore. That was what he decided. Then he went all the way backwards and said, okay, how are we going to do this? How are we going to do this? What do I need from the team? What do I need from the patients? What do I need from me? So the only way he could work that out is if he talked to everybody. So he talked to the receptionist, and the receptionist said, well, you know, the patients are ringing us all the time. So, okay, we need to educate the patients. Do not ring us. We will not run late from the 1st of September. Something he said was, when I'm in there with a consult, I all of a sudden have 3 kids to see as well as the mum. So we have to educate the patients. Okay, this appointment is for you. It's 10 minutes in length. Please don't be embarrassed. Actually, I think we said 15 minutes in length. Please don't be upset if I push you out the door after 15 minutes. But if you need longer than that, you need to let us know. The appointment is for you, not your children, not your husband. It's for you. If you want it for anybody else, you need to make an appointment or change your appointment. And receptionists, I need you to not squeeze anybody into me. I need you not to interrupt me unless it's a pharmacist, another doctor, or my wife. I like his smiles. So it worked. It worked because everybody had input into how this might occur, how we might actually cut down waiting lists. He tells me, when I worked with him, it was probably about a year ago now, he said he still runs to time. Because there was things he had to do too. He bought a little clock on an angle and he timed his consult. So he got very used to looking at the clock and knowing when it was getting close to the end of the consult. The patients were amazing. They would walk in, they would not waste time. They knew they had 10 minutes and they'd go, okay, these are the things I want, here's my list. So it really did work, but it only worked because everybody was involved. The obstacles, the challenges, and the opportunities were, they were able to be seen because everybody had a way of giving input into what might be the problem or what might be the solution. When you involve your team, it does stimulate that input and it gets people quite excited about it. And I am going to tell you about some of the incidences that I've seen. It also ensures that you're collecting data along the way. So long as the whole team's involved in a quality improvement activity, they're going to be able to say things like, oh, hang on, we tried this, but that's not working. Instead of what would normally happen is knew that wouldn't work, knew it from the start it wouldn't work, so I'm not doing it anymore. Okay, so it's a whole different philosophy, I guess, that's applied by those people that are involved in it than those that it's just given to. So let's talk about how we decide how we're going to improve. So what I thought I'd do, because healthcare in Australia sucks, right? Sorry, it does. We're bound by, somebody quoted to me, 187 different pieces of legislation. Great. It changes all the time. Who does change in this room? Put your hand up. All right, I don't like you at all. I don't like change. I hate change because everything just goes really smoothly. Then all of a sudden I've got to change and I think, damn, not only have I got to change, I've now got to get all my people to change as well. It drives me nuts. Unfortunately, that's the nature of our industry. So change is going to happen all the time. I'm going to talk to you about some of the emerging risks. So there's internal influences that will force a change. So it might be something that goes wrong in your practice that prompts you to make a change. And that's really important because I'll give you an example. This was a receptionist who was told by the doctor brought out a HIV result. And he said, you need to fax this to the local hospital, this patient's an inpatient and they want these results. And the receptionist said, yep, sure, no worries. So she faxed it off to the hospital. She got 1 digit wrong in the fax number and it went to a service station. So the service station worker phoned the practice because the number was on it. And the service station worker phoned the practice and the receptionist answered. And he said, listen, I've got this piece of paper here. It says Tom Jones, date of birth, blah, address, blah, HIV count, blah. What do you want me to do with it? The receptionist went, God, that was me. Rip it up. Could you please rip it up? I'm so sorry. I made a mistake. Rip it up. Okay. So who knows about notifiable data breach? Right. Is this a notifiable data breach? Does this need to go to OAC, the Office of the Australian Information Commission? Okay, it didn't. I'll tell you why it didn't. Because that receptionist had discussions with the practice manager, and she knew what she was supposed to do. Most receptionists, I bet you, would go, don't tell anybody, I might get the sack, and just quickly fax it off to the hospital. That receptionist didn't. She went to the practice manager straight away and she said, this is what's happened. Actually, she did one step before that. She said to the guy on the phone, can I just get your phone number? Can I get all your details, where the service station is? I'll keep in touch, I'll keep you informed on what might happen. She then went to the practice manager went to the doctor went to the patient, sat on the patient's bed and went, let me tell you what happened in our practice today, I'm so sorry. And the patient went, oh, I don't care, I don't know that service station, it's no big deal to me, right? So it became non-notifiable to OAC. It was contained, exactly. But imagine if that receptionist had just gone, oh, and just not told anybody, and it had had a bad effect, right? So then the patient did find out, maybe it was his father-in-law or brother-in-law or something working at the service station, or something happened that he found out. Then it would become notifiable. And do you know what else would happen? When OAC come out and look at your practice, they're going to look at whether or not you've educated your people, whether or not you have changed something because that went wrong. And that's what when they decide, and this happens with Medicare reform, this happens with work cover, this happens with, when you're fined if you're fined with Medicare or the Privacy Commission, or when you have an adverse event and solicitors are called in, when you are judged on how bad you've been, they're going to say, did you actually educate and did you do something about it when you noticed that something had gone wrong? So it's really important that we're doing these QI activities so that we can show if something goes wrong that we're actually committed to looking at what we're doing, looking at what's happening in and outside our environment and doing something about it. So we need to look at these external influences that are happening and talk to our team about it so we can be prepared if something goes wrong, because things are always going to go wrong. Some of the things that have happened outside your immediate environment, your practice that affected you, I'm just going to go through a few of them and see if you know what they are. So 22nd of February 2018, what was that? We've already talked about it. Notifiable data breach, yep. So we need to have talked about our stuff about that. We know what happened on the 1st of July, that was Medicare reform. That actually, you know what, we were told about that 1st of July 2018. We were given 12 months to get ready for it. I can't believe that still by the 1st of July 2019, practices are still going, what, notifiable, Medicare reform, what? Shared data, what? So, we get told about this stuff. You need to make sure that you're looking for this information. The 2013 case, Idomeneo versus Gross, does that mean anything to any of you? This was monumental. So this was with HIV again. This was Gross, Dr. Gross, who was a doctor. A patient came to see him to have a HIV test, have a group of blood tests. She was concerned that she had contracted HIV. The test came back positive, but he could not contact her to tell her that it was positive. He tried, he couldn't find her. The details weren't up to date on the computer, and he could not find her. About 9 months later, her partner came in, and he was concerned he'd contracted HIV. They were a new partnership, and he had a HIV test, and he too had tested positive. Now, with HIV, you can actually see around about when they contracted it. They can work that out. So it could be distinguished that he had contracted it in the last 9 months. So since his partner. So that patient, the male, sued Dr. Gross because he had not let the partner know that she had HIV. Dr. Gross sued the receptionist. Why? She didn't do her job properly. She didn't do her job properly. Now, you can't actually sue an individual. Well, you can, but it's messy and horrible. He sued the employer of the receptionist, and it was a shared responsibility. I'm listening. So are we. So, really serious stuff. Really serious stuff. Your receptionist sitting there and working precariously for the doctors, they've got a duty of care as well. So I'm an accreditation surveyor. When I go in and I say, so what are your 3 points of identification? And your staff say to me, Medicare number. I just go, really? Seriously? Are you still giving me that? Because we know, what are the 3 points of identification they have to be asking at the front desk? Name, date of birth, and address. What's the fourth one? No, I wish it was that. It should be that, because that's what we should do. Gender, yeah. So you can say, oh, you're male or female. Crazy, crazy. But our staff don't like doing it. Why don't they like doing it? Because patients get cranky and they know the patients. I don't care. And neither does the national quality safety standards. This is not the college standards. This is not part of your accreditation. This is a national standard. Every specialist is supposed to be doing this as well. I know. This is something that we are supposed to be doing. Every person receiving healthcare in Australia is supposed to be identified properly before they receive the healthcare. It's just a rule. So that's something, that's a typical example of where you would be saying to your team, okay, we've got to get 3 points of identification. They'd be going, well, we can't do it because patients are getting cranky. Okay, what can we do to make sure that we get this right? And, you know, what are the things? There's lots of things I'll come up with. I'll say, well, most of our patients probably have photo ID. How about we get a kiosk? Or how about we get the patient to fill out a form? How about we, get the patient just to give their day and their month rather than their year if they don't want to tell what year they were born. Let me tell you, there's a lot of women patients in Mossman in Sydney that don't want to tell what year they were born. They'd rather pay outright for the fees. So the only way you can resolve that issue of 3 points of identification is talking to your people about how you might do it and letting your patients know why you might be doing it. The privacy principles, they changed in 2017. So it was all about data and collection and usage. So, you need to be aware of that because a perfect example was a case where the on the new patient form it says mobile phone number and the patients are filling it out and a 16-year-old got reminded of her Implanon, Implanon replacement to her mother's mobile phone number. It's a breach of privacy. So are we asking our patients, are we telling our patients what we're doing with the data we're collecting? How are we making sure that they know what we're doing with their data, so including their mobile phone number? What are we going to do with this? Better one than that was a man who, this is a practice that did vasectomies. It was a general practice, but he did vasectomies, and he used to get email addresses to communicate with the patient. And he let his male patient know that his sperm count was 0, and his wife opened the email, and she'd had a hysterectomy 5 years earlier. So that was a breach of privacy, as you can imagine, because she didn't even know her husband had had a vasectomy. So you need to be thinking about if you're collecting emails from patients, if you're collecting mobile phones from patients, what are you doing with that? And you need to tell them because that's going to protect you from breaching their privacy. Does anybody do cosmetic work in their practices? Okay, because there's a case it's being written about now, it's in court at the moment, where a woman that was having, she had cosmetic work done in pretty sure it was a general practice, and she ended up going blind, only in one eye. That doesn't make it any better, I know. But it's a case that's going to change anybody that's doing cosmetic work in their practices, you know, how they do things in their practices. There's been a lot of cyber attacks in Australia, mostly in Queensland, we happen to know. You're a long way from Queensland. But that's a big issue for us, because your receptionist might come in the morning and just be in charge of changing the external drive over and putting the other one in. But if she doesn't do that properly, and if that external drive goes missing and you get cyber attacked, you know, you're going to be in trouble with restoring from your data. You're going to lose data. Your data is very valuable. So you need to be having conversations with your team about what are we doing about cyber, because this is on the increase. What do you do when you walk in and you're the only receptionist on, and it's going to be Saturday morning when it happens, and it'll be the weekend you've gone skiing and you haven't got your mobile phone with you, but your staff's going to walk in and see a big blue screen that says, please pay $2,000. What does that person do? Instead of letting it happen, maybe sit down at a meeting or talk about, hey, cyber attacks have increased. What do we do in our practice? Here's my number, here's the IT guy's number, here's the other number, and it's somewhere where they can find it really quickly and easily, so they know what to do. The big one, the big ochre one that happened in New South Wales, that the receptionist actually said to a patient, this ended up going all over the media, because the receptionist said to the patient, oh, we've been hijacked. We can't get our data. We've had a cyber attack. So the patient went to the media. The media slaughtered Ochre. Ochre is one of the best health groups in Australia, and they got slaughtered because a receptionist said to a patient, we got cyber attacked. You know, it's a pretty simple thing that somebody would do. So conversations about cyber, conversations about other things that you read, like bullying cases and social media cases. So how do you know what to change? How do you identify something that needs changes? You look at what's happening in your practice, you look at what's happening outside of your practice. How do you know what you don't know? You be a member of your professional body. So it's AAPM for practice managers. Has anybody here got Practice Hub? Okay, if you've got Practice Hub, you'll hear about it because we push it out to you. You know, have a look. As soon as you see a legislative change at the top, you know, something's going to happen. We're going to make sure we do things right. Look at your journals, your publications, read. If you're worried about something, talk to your MDOs. You've all got insurance. I hope that if any of you have an Idomeneo versus Gross case, that you have got insurance to cover yourself for that. If you haven't, see Karina at the back later. Networking groups are really good. Is there anybody that, like today, is fantastic? Your PHNs are fantastic. They will keep you up to date. How many of you are a member of a social media networking group? Okay, be very careful. Just because they're on the computer, on social media, it doesn't mean they know everything. I get very frightened when I see people say, oh, can I bill a 723 and a blah, 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 and somebody else writes, yes, you can. I think, what are you doing? Be very careful. Make sure you do the research yourself. Your MBO is there to help you, and your PHNs will help you as well. And your team will help you, I suppose, talk about things that are happening in the practice more than anything. So the QI process, so the quality improvement process is made up of a few different components. So the thinking part is the first part. This is where you decide what you think you want to accomplish. So you might go back to your practices and say, Angela's talking about blah, let's talk about it together. Or you might give your team a bit of advance notice and say, you know what, we probably need to, well, we don't probably, we need to be quality improving. I want you to think about what you'd like to improve. You know, before I joined the band, I was a consultant, and so I would often get that phone call from the business owner, from the practitioner, the doctor, saying, I need you to come into the practice. Before I'd interview him or her on the phone, but before I actually went in to do my assessment of the practice, I used to get, for the 2 weeks leading up to my first visit, I used to ask the receptionist to fill out a little form for me. What they had to do is every day for the 2 weeks leading up to when I came in, every day that they were going home from work, I wanted them to write down, did I have a good day or a bad day? If I had a bad day, I wanted them to write why. So they were writing things like, I got abused by a staff member. I got abused by a patient. I got told I didn't do something well. I couldn't squeeze in a patient and they got cranky with me. You know, these are the things that they're writing down. When you start to, and I advise you to do this with your receptionist. And when you look at that data, you can see there's usually a bit of similarities between what's upsetting your people. And I don't know about you, but I don't want to work in a practice that nobody wants to come to work in the mornings. I want to work in a practice where they want to be there. So I want to change these negative days for them. So I would collect all that information and then work out what we had to improve on. I didn't come up with a solution. All I did was help guide their thinking. So I would say, okay, so this was a problem for you. You got abused by the staff member. So we can't just stop abuse. We've got to do little chip away at it to get that to stop happening. So we might have to educate the patient. We might have to find out why he or she was abusing you, because maybe there's a problem with your system. Maybe you have to update something in your system that might make it a little bit better. So you have to think about, what am I trying to accomplish? Then you have to think about, how will I know that a change has improved? And that's really important, because unless you know how it's going to be improved, you're not going to be able to measure it before and after. And it's important that you measure it. And I'm not talking about measuring it in a maths formula or you know, a printout of your computer, which might work. But you might measure something by interviewing your patients, interviewing your staff, finding out how many bad days they had, you know, for the 2 weeks leading up to the beginning of this QI, and ask them again in 6 months' time, how many bad days for 2 weeks, and just measure that. So it's pretty easy to put a measurement in if you know how will you know if the change is going to be improved. What changes can we make that will result in an improvement? And we'll go into this in more detail. So once you've got this last one, what changes can we make that will result in an improvement? That gives you the ideas. So it's individual things, and we'll work through this. I think I'll do it on the next slide. Yeah. And so that will give you your ideas, and then you start doing this, the doing part, which is where you plan it, you do it, you study it, and then you change it or you act on it. So let's work through the fundamental thinking. So this is the first part of the thinking. This is the overarching. This is when you get your team together and say, okay, what are we going to do? So you need to consider, what exactly is the problem? You need to work with them to set realistic goals and keep it simple. Don't get too bogged down in this. Just keep it really basic and really simple, especially when you do your first few quality improvement activities. Just do something really simple. And that will be your goal. Okay? When we get back from our break, we're going to start populating. And this is the first step in your populating of your template, is coming up with your goal. And we'll give you some examples of what they might be. I'll work through this process with a quality improvement activity I did many years ago now. Gosh, I can't even remember when it would have been. It would have been about probably 2007. And this was a practice we had amalgamated. It was 2 GP practices amalgamated and came into one. So we took all the patients, all the doctors, and all the staff. So we found that our phone system just wasn't working. So all of a sudden, instead of 40,000 patients, we had 80,000 patients that were trying to get through on our phone lines. It was a disaster. So the girls at the front desk just couldn't keep up with the phones. Patients were complaining. They would get into the doctor and complain about how many. They would actually time, and they would bring in bits of paper to the consult and say, this is how many times I rang your receptionist, and look how many minutes it took to get through. Doctors wouldn't even ring reception if they were going to be late because they couldn't get through. It was just a disaster. So we knew that this was a problem. So our goal in this particular, when we started thinking about what's our biggest problem, our goal was to decrease phone calls to the front desk. That was what we came up with. And we actually, I think we went a little bit further than that. I think we said decrease phone calls to the front desk between 8 and 12. Because then we had to start working out what we were going to do to actually see if we were going to be successful. Which brings us to the next step. And this will be the next step in your template when you come back from a break. How will you know if an improvement has been made? So the thing that we did was we thought about, it was pretty simple, isn't it? We had to work out how many calls were coming through and then work out how many were coming through after we'd implemented this activity. So I actually got a receptionist. I got all the receptionists. I had every morning when they opened, they had a blank A4 piece of paper next to them. And every time they answered the telephone, they would put a little tick. We broke it up into 4 columns. It was very interesting because when I said to the staff, what do you reckon most of the calls are about? And we worked out that it was pretty well, want an appointment, want results, want to talk to the doctor, or miscellaneous stuff, right? So we worked out that if we could break it down into 4 different columns, which was really quite astounding. I thought we'd get lots more different phone calls. And I think that was a fair while ago now. I think that were the 4 columns. So they would just put a little tick in whichever phone call they were getting for that in that column. So they only did it between 8 and 12 each day. And then I put it all together, and you would not believe how many phone calls we were getting. When I took that to the doctors, because the doctors were sitting in the meeting saying to me, can you get a staff to answer the phone? So when I said to them, this is how many phone calls we get between 8 and 12 on average each day, they went, oh my God, really? And it puts it all into perspective. So that was how we knew that we had a problem, and we knew that we had to measure exactly how many phone calls we had now and how many we get in 6 months' time. Or actually, I think we did 3 months' time. Okay, so we very much involved the team in collecting that data as well. So I think when we looked at the results of this, we found that that, as I said, we can put it into 4 columns, and that was a really important piece of information as well. So when we worked out the 4 different columns, we could then work out what we could do with those 4 columns. So things like ringing for results, well, what can we do about that? You know, an appointment, pretty standard, we know what we have to do with that, but what could we actually do? How can we stop people from ringing for results at a certain time? And, you know, what were some of the other things that they were ringing for that we might be able to postpone rather than have it happen in that busy time? So that was really important information that we got as well. And then that helped us design what we were going to do, which brings us to our 3rd step. So what changes will we have to make? So these ended up being the ideas. So some of the ideas that our team came up with in this particular case it was actually very funny. One of the receptionists said, well, it's quite clear we need a new phone system. And we did. You know, we had something like 3 incoming lines and 1 outgoing line. That is not enough for 80,000 patients. So clearly we did need a new phone system. Somebody else said, well, why don't we take a staff member out of play so they're not on the front desk at all. All they do is take phone calls and they sit at the back desk without even looking at the front. So that was a good idea as well. The other thing that we did was we had to educate patients about when not to ring for things. So they became our 3 different ideas, right? So we had 3 ideas that we thought would solve this problem. So the first one was we needed a new phone system. The second one was we were going to have somebody allocated to taking the phone calls. And the third one was that we were going to defer so educate patients so that they didn't ring about certain things. So it was really, really interesting doing that. And then that developed, from there we developed a whole lot of ways that we might do that. So we'd already set our goal, and then our plan was, well, what are we going to do? So this is on your template, you'll see that the plan is where you actually decide how you're going to sustain, if you like, each idea. So the idea for us with a new phone system was pretty simple. We wanted a phone system with more incoming lines. We wanted it on a rotor. We needed to be able to put a message on it that educated patients. We needed to be able to know who was on hold for the longest rather than, just picking up randomly. We wanted to pick up the one that had been on hold for the longest. So that was pretty simple. Educating patients. This was a really interesting one. So a couple of the things we did was we had a message on our phone line that educated patients. We also had a little bit of paper that we handed out to patients every time they came in and were sitting on the counter, and we'd say, just have a read of this. And it said something like, we've been having terrible trouble with our phone. Patients were really happy with that because they didn't have to tell us. We were acknowledging we had a problem. We want to do something about it. So what we're going to do for starters is please don't ring for results if you're going to ring for results, it has to be between 2 and 4 in the afternoon. We also did a little printout that the doctors, and there were a few other things, but we did a little printout for the doctors that was supposed to be attached to any referrals for pathology that said, do not ring us, we will ring you. If you do feel you need to ring us, ring between 2 and 4. So the doctor had to attach that to each of the referrals each time we handed one out. So they were the things that we did to make that idea work. And then what was the other idea that came out of that one? Bring someone out of that room. Yes, that's right. So then we thought, okay, well, what's our roster? One of us, and it was me, that looked at the roster and worked out who was going to be in charge of their phone, and that priority was just for appointments. And if it was for anything else, they said, I'm just going to pop you on hold, and somebody will pick up soon. So that then that would go to somebody else to pick up. So the person that was off the desk, they were just in charge of taking appointments, which was predominantly most of the calls. So it was very interesting because when we put that into place, we executed it. It all was happening happily, and then we studied it. And I want you to guess which one failed. Think about what I just told you. We'll go specifically to the idea of educating patients. So we had 3 different ways that we were educating patients. We had a flyer, we had our answering machines, we have your website now. An answering machine, and the doctors were attaching a bit of information to the referral. What do you think didn't work when we studied it? Of course, the doctors didn't attach. So how do we had to, when we studied it, we went, it's not working because the doctors aren't attaching. So we had to investigate that. We had to start watching and working out, well, who's not attaching? How can we make it easier? We had to name and shame. We had to talk to the pathology, the pathologist was next door, and tell them to tell patients as well. We had to open our eyes at the front desk as well and just have a look. If we could see they had a referral form, we'd go, did doctor give you a form with that? Well, here you go. So that we were studying it and seeing why it was failing. So you need eyes and ears at the front desk to see why it's failing as well. And you need to be asking if a patient is still ringing and not being compliant. You might have to say, well, no, I thought did doctor not tell you that we have to ring, blah, 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 that you have to ring between 2 and 4 or whatever. So really, really simple PDSA. And obviously the act was we had to change a couple of things, and then we were ready to move on to our next. Okay, really simple, isn't it? Okay, so I think what we might do now is we might have a little break because it's 7:30, almost 7:30. I've got a slide up here for us to set our goals when we come back. So when we come back, I'm going to get you to work in the groups on your table. I want you to pretend, because remember that when you're setting a goal back in your practices, it's going to be with your team. So here you're really going to be working solo. So it's actually harder here than it is when you're back in your practices. But I want you to pretend that the people that you're working with are kind of your team. So decide what you want to change, or you want to work on as a group. Remember, this exercise is really just about getting you familiar with how to do things. But think about something that you would like to take back to your practices. So you've got to start already. So let's have a break now, and then we'll come back and do that shortly. Get started again. You should have your blank template in front of you. If you just pull that out, I want you to think about when you're deciding what your quality improvement is, what it's going to be. I want you to think about what I've talked about this morning, but there's two other things that I think are really relevant to you at the moment that you might want to just think about. And this might not be for tonight, but something that you take back. What's just happened in Victoria that we've led Australia? Sister dying. Now, we have a real issue with general practice and ethical dilemmas. So this could come under an ethical dilemma that you need to have a discussion with your practitioners on whether they're happy to participate, because your Victorian patients are going to be looking to you for direction with this, and you need to know in your practice if all your doctors are okay with it or whether they're not okay with it. And if you look at how you manage ethical dilemmas in the standards, getting ready for accreditation, there's certain things that you should be doing. So if you've got a doctor in your practice that says, I want nothing to do with assisted dying, then there's somehow that you need to make your patients aware of that so that they can choose another doctor to help them. The other thing that we're seeing lately, this just fascinated me, so I want to share it with you. We're getting a lot of calls at the moment about companion pets. Is that happening to any of you? So this is, people that have a companion dog and they want to bring it to a consult and take it to. No. I know. But guess what? In America, they have companion pigs, companion cocks, as in roosters. So it's coming. It's coming. So what do we have to do? Because you could have a situation now where a patient walks in with, an Alsatian and says, this is my companion pet, I'm taking it into the procedure with me, and your receptionists are going to have to know what to say. And it's really interesting because I only just discovered that companion pets have to be certified. So there's certification that the person has to show you, because that companion pet has to be safe to the rest of the patients in your waiting room and your team as well. So your receptionists have every right to say, look, yes, we understand companion pets, we love cocks, or pigs, or whatever it is. Sorry, that's what they call it in America. Roosters. Yes. Gosh, you people have got a dirty mind. So your receptionists have to know what to say. Yes, look, we accept that you've got a companion pet, but in interest of our patients, we must see licensing because we have to make sure it's safe. And you might have to make the decision on whether people with companion pets come at a different time than your patients that have got allergies. So and only your team are going to know which patients in your waiting room are terrified of dogs. You're not probably going to know that. So there are sorts of things that I want you to think about. You also might want to think about, and we've already touched on some of these, so Medicare reform, you might want to think about notifiable data breach in view of the HIV case and just revisit that with your staff. You might want to think about cyber attack and what that means, how your process or your system in your practice might need to be improved. Might be about communication within your practice. You might have a fractured working group, a fractured team that you want to bring together. You might have low morale in your practice that you want to bring together. Somebody last night at this presentation, that was one of their activities. I've got a few pre-populated templates which I'm happy to give to the PHN and they will circulate for you, but your PHN has really great templates as well that are already populated for you. I think you're only looking at you're not doing the PDSA part, are you? You're just doing the goal? Or
just the goal, just the first section of it.
Yeah. So it'll be just on your template, it'll be just that top box that the PHN has filled out. You'll have to do the bottom boxes. Okay, so you're going to be working together now. The slide that I've got up on the screen, point 1 is how you are going to populate the very first box on the top right. So it's headed with, what are you trying to achieve? I want you to talk amongst yourselves. I'm just going to give you about 5 minutes to talk amongst yourselves and come up with, what are you trying to achieve? Think about what you want to do in your practice, what you want to change. Okay, what's a problem at the moment? What are you nervous about having listened to me? And don't say everything. All right. Okay, are we ready to move on to the second box now? So this is the box that's heading says, how will you know the changes and improvement? What I need you to think here is just what will you be measuring? What will you be thinking about? So for example, if you're doing decreased waiting times, if decreased waiting times is in your goal, that's your goal, you might have your measurement might be less double booked appointments. It might be more available appointments on Monday, Wednesday and Friday. It might be paperwork is booked as an appointment. It might be patients get seen within 15 minutes of appointment time. So just think about how you might measure. And this is where your team's going to be really important to you, and you haven't got that here today, unfortunately. But think about how are you going to measure if what you're trying to do, how are you going to measure if box 1 is effective? So here, box 1 is better appointment book management, but in box 2, we've got less crowded appointment book, fewer patient complaints, ability to triage without stress. Okay, I'll give you some other examples. Say your goal, so say what's in your first box is less confusion and fractions between the clinical team. How will you know it's going to be an improvement? Maybe your receptionist will understand their role when changing their role in a change. The doctors will receive less complaints from patients during consults. Receptionists will feel informed and competent in their job. Let's say your goal is an efficient recall system. Maybe how you'll measure this is recalls will take 30 minutes instead of an hour. No double contacts with patients. So, you know, if you're contacting patients twice because doctors are forgetting to take the recall out, you know, that you might measure if patients are being recalled twice or if they're on the list that shouldn't be on the list. If you're having trouble, in your printout of your presentation, on page 4, in your actual presentation, it's got the fundamental thinking questions. So point 1 is your goal, point 2 is the one we're working on at the moment. Just have a look at that and revisit what it says, and then that will help you think about what those measuring, what you're actually measuring. So it's on page 4 of your handouts. So you'll see the fundamental thinking questions. There's 1, which is box 1. 2, how will you know that the change is an improvement? That's the box we're working on now. And then page 5 will be the next box that we're about to start working on shortly. Everybody, if I can just have your attention just for 1 minute. If you're ready to go into the third box, please go ahead and do that. If you turn to page 5, I'm not sure what slide number it is, but it's under fundamental thinking point 3. That will give you what's got to go into that third box. Now, your third box is your ideas. You only really want about 3 to 5 ideas that come out of what you're trying to do. So there'll be 3 to 5 ways that you might achieve what you're trying to achieve. And those 3 to 5 ways, they're your ideas. and then that's what you do the PDSA on. Okay, so that's when you implement the idea, you look at it, you decide how it's going to be implemented and so on, and then you study it and then change it if you have to. Okay, so the box 3, if you look at page 5 of your handouts, it will tell you it's fundamental thinking step 3, and it's your ideas. There should be 3 to 5, and then we're going to work on one of them once you've written 3 to 5. We're going to work on 1 or 2 of them in the PDSA. Okay, so I'll give you 5 minutes to come up with 3 to 5 ideas for the third box at the top. All right, let's move on to our next step in the process. And really, this is probably the final step for tonight because you're not actually going to be able to do your activity. You're not going to be able to study your activity and you're not going to be able to act on it. But I want you to now do your plan. So in your third box was your ideas. Now you're supposed to have 3 to 5 ideas. Underneath the top row, you've got a column, heading called Idea 1. You write in there one of the ideas out of your top left-hand box, right? Just one of your ideas, and then you can write another idea in the second one if you want to, but let's just start with the first one. So Idea 1 is one of your ideas out of your top left box, and then you're going to start to plan. So pick an idea out of your box and put it under that, next to Idea 1.
Sorry.
Yep, and on the screen I've put up what you're going to do, how you're going to plan around this idea. So this is, what are you going to do, who will be involved, when will it happen, where in the practice, predictions, data to be collected. Okay, so this is the actual planning part for the idea. The ideas come out of your third box. All right, ladies and gentlemen, we might finish up there. We can't really do the do and the study and the acting because that's later. Can I just say to you that there's 2 acronyms I want to give you. And I won't write them up because the webinar people won't see it. The acronyms are KISS. Keep it simple and sweet or stupid. So keep it simple. Don't make a fatal mistake that most of us make, and I did as well when I first started working on the templates that I've worked on for Practice Hub. I started to get myself in a total big muddle because I was going too deep and doing too much. Honestly, your team will help you keep it simple. It is much easier to do a goal setting and a PDSA with your team around you than doing it by yourself. So get them in and they'll come up with things that are really simple. The other thing is everybody's favorite radio station, WIIFM. What's it stand for? What's in it for me? So you're never going to get your people to participate if they can't see what's in it for them. So guide them to a QI that is going to make life better for them. So I take you back to what I said at the very beginning. Ask them what's bothering them in the practice, and you'll be surprised what they come up with. And if you have a feeling about something that you've heard me talk about tonight that you'd like to implement, maybe tell them that story first and get them a little bit scared like you possibly were tonight, and that will stimulate them to think about the simple strategies that you might be able to implement. I'm going to finish up now on this particular topic, but the 3 of us are here now for questions about anything. I work on the standards committee around the 5th edition. If anybody's got any questions about accreditation, about illegal stuff that's happening out there, anything, I'm here if you need me, but so are the PHM team.
Yeah, so if anyone has any questions for us around QI or anything to do with quality improvement or what the PHM is doing, anything like that, feel free to ask. For those that are on webinar, type your question into the question box and we've got someone sitting at the computer that can read out your question. So So yeah, we'll leave it open to the floor and to the webinar people. No questions in the room, isn't it? We'll wait for the webinar people, see if there's any questions on webinar.
I've got a question. You probably answered it the other day, but where do you record all this? So where do you keep it? What do you have,
Yeah, there's depending on your practice setup, there's different ways. So we can help set up with like an Excel spreadsheet register that lists all the different quality improvements, your PDSA templates, having those either on a computer somewhere or printed out and kept in a folder if you prefer.
Practice Hub has a folder which I think we're sending them out in the next few days, a few templates for you to look at, which we'll upload the PHM ones as well. So you have a folder in your Practice Hub that will be QI. But if you haven't got Practice Hub, you could put it in a folder on your server. It just has to be available if ever you get audited, which they won't for a little while.
So for those that are registering for PIP-QI, as most people in the room here registered for PIP-QI, we've gone through that process. What we require from practices is just your PIP ID number, so that we can record that. So when we report to the government that yes, you've sent in your de-identified data, we just have to provide that PIP ID number to them. Just email that through to your practice facilitator. Or if you're unsure who that is, we have a qi@westvic.phn.com.au email as well that you can send it through to. Most of you will probably have been in contact with your practice facilitator recently or will be in the Geelong region. We've just got a couple Gemma, sitting up the back, is one of our new practice facilitators, and we've got Natalie as well. So there's now 4 of us for the Geelong region. So we are working through the numbers of practices that we have to contact and see how everyone's getting on and assist where we can. Any other questions coming up, Gemma? No questions from the webinar. Any more questions around PIP-QI, what you need to be looking at? Common ones being around the 10 improvement measures. Do you have to be looking at those? You don't have to be. You just need to do a quality improvement based on your clinical data.
And you have to document that.
You have to document, yeah.
In case you get audited, which you won't be for some time.
Unless accreditation, if you're coming for accreditation, your surveyors will be asking for something.
The number that you have to have? Is it one every year, or there was one of
what's that?
The number of quality improvement activities that you've done?
No numbers.
Number?
No.
Not yet.
So in terms of proving it, like documenting it, if we have a PDSA there that shows what we've planned, studied, done, and this is our results sort of thing, is that what they're going to look at? That's enough. So as long as we have some of them in place from different times of the year and just continue to put them in place as we come up with a new idea, that would be enough.
That's exactly enough. So for some quality improvement activities might be something that goes over 6 months long, and you might have little PDSAs sort of over those 6 months. So you've got that documented. That's all you need to do. You may have those small ideas that only take a month to do, just as long as you're documenting it. No questions, Gemma?
No questions.
No. Okay. Well, I'd like to thank Angela for coming down and presenting to us tonight. Thank you very much. We have recorded the webinar, so it will be uploaded onto the Learning Hub in the next, hopefully, few weeks. We will be communicating via the communique when new things are being uploaded onto the Learning Hub. Also, you will have been sent an evaluation link via email at about 5 o'clock this afternoon. So if you haven't received it, please let us know so that we can send it through. We would really appreciate if you could send out a complete evaluation. It helps us inform how we're doing, also some ideas of topics that you may like for the future as well, and also provides Angela with some feedback as far as her presentation goes too. And yes, that's just about it. Anything else that you can think of, Gemma?
Unless they've got ideas for future events.
Yeah, so if you do have any ideas of any other future events, let myself or Gemma know, but otherwise, yeah, complete the survey and put it in on that too. So we're keen to sort of have a few more practice manager network sort of events, as well as practice nurse events, as well as to continue with the practice support meetings as well. So, yeah, any questions, feel free to contact us.
Thank you.
Thank you.